So this week we're going to talk about osteoarthritis, facetogenic pain, neuropathic pain, and headaches. So osteoarthritis. I know everybody works with this probably every day in your office, but just a good reminder of some of the neurophysiology and some of the chemical mediators that play a role in osteoarthritis. So on the left of the screen you see a normal knee, and then on the right of the screen you see an osteoarthritic knee. Not really sure if that's a 100% depiction, but basically you're going to have some degeneration and changes in the joint space, just like you guys know. So here's a little better picture. You see some spurring of the femur bone up top on that right picture. You see some degeneration in the articular cartilage, and then of course on the tibia you'll see some spurring of the bone. So there's obviously phases of degeneration and phases of osteoarthritis, but basically the way I speak with patients is that if you don't move stuff, you're not going to get good nutrition to the area. Without the movement, without the nutrition to the area, you're going to get degeneration, and that'll sometimes come in the form of osteoarthritis. So I know all you know this, but there's a normal spine, nice healthy disc space, good facet space in between. You got foramens so the nerves can come out. When you have that degeneration, you've got the bones basically growing together, the discs starting to get squished, spurring, some lipping, all that stuff. So I just thought this was a really cool picture. And then if anyone, I know this is a neurophysiology course, but I really liked this guy. I think he's a physician's assistant, Jorge Munez, and his website is medcomic.com. He's just got some really cool pictures, and I know we go through a lot of the literature, but it's always fun to see how people learn things, and I think he probably learned because he drew really cool pictures, and just a good way to remember. But you always have to remember with osteoarthritis, it's a degenerative disease. Most of the patients will complain of morning stiffness that's lasting less than 30 minutes. Movement's going to help it. You're going to see some Heberdine's nodes and cartilage loss, and then it'll be asymmetrical in nature. Opposing to rheumatoid arthritis, which is more of an autoimmune disease in nature, they're going to have morning stiffness, but it lasts a lot longer. The movement doesn't really seem to help it because there's an inflamed synovium within the joint space. It'll present as more symmetrical than asymmetrical, and you're going to have the extra articular joints that are involved. So, getting into some of the serious stuff here. So, neurophysiology of arthritis pain. I like this article. Again, as we finish up the class, a lot of it starts within the book, but then we've got to go to the literature to really dive into some of this pain stuff and see what people are saying. So it's not too late of an article. It's 2012, but the World Health Organization ranks musculoskeletal disorders as the most frequent cause of disability in the modern world, affecting 1 in 3 adults. So 1 in 3 adults are suffering from musculoskeletal disorders, arthritis. So it's important that we know our stuff and we know how to treat patients and help them get out of pain. So here is, this article went into a little bit more of the chemical side of osteoarthritis and of arthritis. So it was kind of cool because they did speak about how, even though it's not an autoimmune disease like rheumatoid arthritis, there is inflammation there. And you've got to modulate the inflammatory components to help people with pain. So I'll read through this. The neuromodulators that can be released from the nerve terminals, as well as mast cells and macrophages, to alter afferent mechanoreceptivity. You've got those endovanilloids, the acids and noxious heat that can activate transient receptor potential, vanilloid type 1, which we've seen that before in our other lectures, the TRPV1 receptor. It leads to the release of substance P, which subsequently binds to neurokinin 1 receptors. Proteases can cleave and stimulate protease-activated receptors, or PARs. And so thus far, PAR 2 and PAR 4 have been shown to sensitize joint primary afferents. So that's something I didn't know. I know everyone can sleep at night fine not knowing that, but the protease-activated receptors, and so far PAR 2 and PAR 4, and I'm sure past 2012 they found more, but those seem to really sensitize the joint primary afferents. And then the endocannabinoid anandamide AE is produced on demand and synthesized from NAPE under the enzymatic actions of phospholipases. So a portion of the AE will bind to cannabinoid 1 receptors, leading to neuronal desensitization. And I know we've talked a lot about this, but we haven't really talked about it regarding arthritis. So the unbound AE will rapidly be taken up by the AMT before being broken down by a fatty acid, FAAH. You don't have to know those pathways, but the cytokines, tumor necrosis factor alpha, interleukin 6, and interleukin 1 beta, they can bind to their respective receptors to enhance the pain transmission. So that's important to know. When we're dealing with these inflammatory components, these neurogenic inflammatory components of pain conditions such as osteoarthritis, we have to know that if we can affect at the peripheral area, if we can affect not only the environment but also make changes to the cytokine makeup in there, the TNF alpha, IL-6, and IL-1 beta, then you can actually help the patients get out of pain. And that's why most patients come into the office. Of course, some want to get better function back, and they will get better function back. But one of the most important things for everyone is just to help people feel better. So there's ways to do that. Some people use some gels to help relieve pain, and you can actually use different types of gels to make the environment a little bit more alkaline as opposed to acidic. So there's some gels out there that do that, and we'll use those in our office to help patients at least get out of pain and then fix structure and function in the joint, and then get mobility back, structural integrity back, and then hopefully keep them out of pain long term. So I know this is a long slide with a lot of stuff in it, but I think some of the stuff that we may talk about on the final exam is just the TNF alpha, interleukin 6, and IL-1 beta. And then I might throw in a little tough question about PAR 2 and PAR 4 about sensitizing the primary afferents. Because when primary afferents are sensitized, they're going to cause pain. So this paper went into some of the cytokines. So the actions of various cytokines in the joint neurophysiology studies have featured quite prominently recently. And interleukin 6, for example, is a cytokine that will typically bind to the membrane-bound IL-6 receptor. IL-6 can also signal by binding with a soluble IL-6R to produce a complex. The complex will subsequently bind to a transmembrane glycoprotein subunit 130 that allows IL-6 to signal in cells that do not that basically don't express membrane-bound IL-6R. So what does all that mean? Basically, IL-6 and SIL-6R, they're known to be key players in the systemic inflammation and arthritis, as upregulation of both has been found in the serum and synovial fluid of patients that have RA. So I know that's not osteoarthritis, but it's good to know, right? Because if we're dealing with an autoimmune component, if you guys do any nutrition and you address the autoimmune nature of RA, you also have to really look at the systemic inflammatory components and the cytokines that are contributing to it, like IL-6 and other factors of IL-6. So transient receptor potential channels, so we mentioned that just on that diagram earlier, but in addition to thermosensation, chemosensation, and mechanosensation, the TRP channels are involved in the modulation of pain and inflammation. So I just wanted everyone to know that they play a role in the modulation of pain and inflammation. And the TRP channels, they're a group of non-selective cation channels that act as integrators of various physiological and pathophysiological processes. So there are some genetic anomalies. I think it's always important to remember that some patients, and this is becoming a little bit more popular in primary care, is looking at genetic polymorphisms and seeing if patients can tolerate certain types of medications based on their genetic makeup, or just tolerate different types of nutritional supplements based on their genetic makeup. So one particular polymorphism, which is this crazy guy with lots of numbers, RS8065080, it alters the sensitivity of the TRPV1 receptor to capsaicin. And individuals carrying this polymorphism, they're less sensitive to thermal hyperalgesia. So based on that genetic anomaly, a recent study examined whether OA patients with that genetic polymorphism experience altered pain perception. The research team found that patients with this asymptomatic knee-OA were more likely to carry that polymorphism than patients with painful joints. So that's a good one to have. So in that case, having that TRPV1 genetic polymorphism will alter your pain perception for whatever reason, just the way it works. And those patients that had OA, I'm assuming at the same level as the ones who are symptomatic, were asymptomatic, which is pretty darn cool. So genes always play a role. I always tell all of our patients, they're always like, well, these are, my parents had it. And I always say, well, we have to talk about epigenetics, because your genes are your genes, but genes can be turned on and off. And not only that, your genes are so different from everybody else. There are genetic anomalies and genetic polymorphisms that'll basically, it'll just totally, completely change the way that you interact with your environment. So just something to remember. I thought that was cool. They mentioned in the article. And if anyone wants any of these full articles, I can post them for you. So part of the conclusion, I'll read the whole thing. I think it's important. So the hurdle of treating arthritis pain effectively still remains. So great leaps are trying to be made in understanding the neurophysiological processes that are responsible for the generation of joint pain, but new targets are being discovered continually. So while the mechanisms behind the known pathways are being further defined and refined, targeting one specific receptor ion channel is unlikely to be the solution to normalizing the joint pain, but rather a polypharmacy approach is indicated in which various mediators are used in combination during specific phases of the disease. I don't 100% disagree with that. Obviously, we're alternative practitioners. Polypharmacy is, in my opinion, sometimes a gamble, especially just what we talked about with genetic polymorphisms. But, that's the way sometimes things are approached. Unfortunately, when you do have arthritic pain, you can do so many good things from a receptor-based therapy approach, like doing chiropractic or doing physical therapy, that you don't need medical intervention. But if it's bad enough, they may respond to some sort of medication. But unraveling the functional circuitry at each level of the pain pathway will also improve our knowledge of how joint pain is generated. I thought that was an important statement. We always have to remember, patients that are coming in with pain is not just pain at the localization of where they're having the pain, right? There's going to be changes in the brain that we've spoke about. We also have to understand the biopsychosocial aspect of it. So, what is this pain keeping these people from doing? Have they developed some sort of neurobehavioral disorder because of this, like anxiety or depression? Are we addressing that along with the pain? Are we meeting these patients where they're at, or are we just getting them in there and doing what we know and seeing if it works, and if it doesn't work, we get tired of them and then pass them along to the next practitioner? Really taking the time to understand where the pain came from, how the pain is affecting their life, what changes may have happened in the brain, what levels of dysfunction in the nervous system are acting up. Is it more peripheral? Is it more central? Then you can really make some positive changes in these patients' lives. So lastly, just to wrap it up, identifying the peripheral mediators of joint pain will allow us to control nociception within the joint itself and likely avoid the central side effects of systemically altered pharmacotherapeutics, which is huge. Or you can intervene with alternative care, start low and slow. I always tell people who are having pain, you got to start with something. So like massage, physical therapy, chiropractic, acupuncture, anything like that, to see if you can just modulate the pain pathways or the patient's perception of pain. And then if that doesn't work, continue to move forward. But there's always so many other options than just taking a medication for it. So Fassett pain or facetogenic pain, Fassett syndrome, as all of you know, it's an articular disorder related to the lumbar facet joints and their innervations. It produces both local and radiating pain. So excessive rotation, extension, or flexion of the spine, such as repeated overuse, it can result in degenerative changes to the cartilage of the joint, and it may involve degenerative changes to other structures, including the IVDs. So I just like this little picture here, but basically you're just seeing an inflamed facet joint. And, we have to remember these guys have little tiny padding, and when there is some major pains there, sometimes they may need medical intervention. We do a lot of personal injury in our office, and if patients aren't responding well to our therapy, sometimes what we'll do is we'll just refer them out. And some of our patients have responded really well to basically injections, like steroid injections, at the site of pain, sometimes at the facet, and it really seems to help them progress and get over the hump. So I'm not saying medication's ever bad, but you have to just really remember the localization of pain and where it came from and everything else. But facet pain can be pretty much a bummer for some patients. But cervical facet syndrome, so the axial neck pain, it's rarely going to radiate past the shoulders, and it's usually unilateral in nature. So instead of having like a radiating nerve root sort of pain, with the facet pain, it's going to be sclerotogenous, where it'll just be from the spine and out into, the more of the intermediate periphery, so more of the shoulder area, more like of the back and on the lats, just like it shows in the picture there. But they'll have pain with and or limitation of extension and rotation. Of course, we know that because of the way that the facets sit. If you extend, you're going to have some decrease in the joint space. If you rotate left or right, there will be decrease in the joint space with that as well. Flexion might actually help some patients because it opens up that facet joint space. But we can't have people walking around with their chins tucked to their chest all day. So tenderness will be upon palpation, and the radiating pain locally or into the shoulders, upper back, and it'll rarely radiate down in the front or down an arm into the fingers, such as a herniated disc might or some sort of nerve root lesion. So I like this picture. Just shows some areas. Every patient I see every day is so different, just a little bit different, and sometimes they'll describe these to a T, and I'll say, oh, okay, I kind of have an idea of what's going on. So this picture is it's helpful. I use it just as a reminder in my clinic, just to remember some of the, not the nerve roots, but just know where the facets might be an issue. So lumbar facet syndrome, pain or tenderness in the lower back. I think this is probably the biggest one that we see in our clinic for back pain. So local tenderness or stiffness alongside the spine in the lower back. Pain, stiffness, or difficulty with certain movements, such as standing up straight, getting up from a chair, basically putting your back into extension. Lots of pain may occur with hyperextension, and they'll have the referred pain from the upper lumbar facet joints. It can extend into the flank area, it can extend to the hip or the upper lateral thigh. So referred pain from the lower lumbar facet joints, it can penetrate deep into the thigh and laterally and or posteriorly. So that's that from picture there. L4, L5, L5, S1 facet joints, they'll refer pain extending into the distal lateral leg and sometimes into the foot. I don't really see it that much into the foot, but I will definitely see it into the distal lateral leg. So again, just another good picture here with a couple of different facet locations. And don't take this word for word. Everyone's going to show up a little bit differently, but these can kind of be some of the areas of complaints for patients if their facets aren't working good or if they're inflamed. So pain originating from the lumbar facet joints. I had a difficult time finding some neurophysiology of facetogenic pain papers in the literature, but this one seemed to be pretty good. So I'll just read the abstract, or part of the abstract, I guess. Although the existence of a facet syndrome, it's long been questioned, it's really now accepted as a clinical entity. It depends on the diagnostic criteria. So the zygapophyseal joints account for about 5 to 15% of cases of chronic axial low back pain. Most commonly, facetogenic pain is a result of repetitive stress or cumulative low-level trauma, leading to inflammation and stretching of the joint capsule. The most frequent complaint is the axial low back pain, with referred pain perceived in the flank, hip, and thigh. No physical examination findings are pathognomonic for the diagnosis, and some of the strongest indicators for lumbar facet pain is when they get better after they get some sort of injection. So when I do refer out to one of our local MDs, MD neuro guys for this, when the patients come back and they say they feel amazing, I'm like, okay, it was probably just a chronic facetogenic pain. Some of the patients get better, but I'll just have those one or two that just aren't getting better with the stuff that I know, and we'll refer them out and they get better. So if anyone has any other really good information on that, please share it in the class. I know we're all practitioners here, and some of you have been practicing longer than I have, so I'd love to learn from you guys as well, and gals. So pain emanating from the lumbar facet joints is a common cause of low back pain in the adult population. This gentleman right here was the first to describe the syndrome in 1911, and Gormley is generally credited with coining the term facet syndrome back in 1933. So people have been having diagnosed facet pain for almost 100 years, which is nuts. Facet pain is defined as pain that arises from any structure that is part of the facet joints, which includes the fibrous capsule, synovial membrane, hyaline cartilage, and of course the bone. More commonly, it's the result of the repetitive stress that we mentioned, the cumulative low-level trauma. What happens is that this leads to inflammation, which can cause the facet joint to be filled with fluid, and it will swell. That in turn results in a stretching of the joint capsule and subsequent pain generation. So the prevalence rate of pathological changes in the facet joint on radiological examination, it really depends on the mean age of the subjects. So the RAD technique used and also the definition of what an abnormality is. I've seen some alterations in the some sclerus buildup of the facets on some x-rays and radiology, but this paper mentioned that degenerative facet joints, they can best be visualized using CT scans. So that's another option. If we're having this chronic low back pain, it's not getting better, seems like it's sclerotogenous and facetogenic in nature, it may be good to either refer out for a CT scan if you're not seeing anything, or if your DAC bar or no one's read a report that shows facet issues. Just send it out for a CT, see if you guys see anything, or again, you can send the patient out to get a some sort of injection to see if that helps. So neuropathic pain, I won't talk too much about it because we've spoken about it in other lectures. But again, just since repetition is the language of the brain, we'll just go over it very briefly. But it's pain initiated or caused by a primary lesion or dysfunction in the somatosensory nervous system. It's usually chronic, it's pretty difficult to treat, and it's often resistant to medications. So if you can remember too, the differences between peripheral and central neuropathic pain. So peripheral is pain caused by lesion or disease of the peripheral somatosensory nervous system, and then pain is caused by central. So peripheral meaning the nerves, central meaning spinal cord and brain. So this was one of my favorite papers that I read and that I've went over with the class, but if you have time, read through this paper. It really discusses neuropathic pain pretty well. And just as a reminder, it's caused by a lesion or disease of the somatosensory system. It includes the peripheral fibers, your A betas, deltas, and your C fibers. And I've recently learned there's 4 different classes of C fibers, and they all play a little bit of a different role. So, just keep that in mind too. It's always never as simple as sometimes we may think. And also central neurons affects 7 to 10% of the general population. Multiple causes of neuropathic pain. It's an incidence likely to increase with the aging population, with the increased incidence of diabetes mellitus, and then also patients who are surviving from chemotherapy. So I had a patient come in today. I'm working with her daughter. She developed, it's actually a pretty interesting case. She developed right side motor tic after being on prednisone for eczema. Her eczema went away, and then she started to develop these motor tics. And we were working with her. We're getting really good results. And then her mom asked me if we could do anything for diabetes mellitus, and then and this was a few weeks after we went over this lecture in class, and I said, of course, like the nerves can regenerate themselves, but it turns out he's drinking lots of different delicious soda or pop or sugary beverages, and his diet isn't great. So I told her, if he wants to undergo care and he wants to rebuild some plasticity in his nervous system, it's really important that the chemical environment internally is healthy and well. You can't build plasticity in a bad system, so there has to be good nutrition and good fuel in order for your brain to be able to appreciate the therapy and the stimulation to build positive plasticity. So that's just another reminder when you're working with patients. If you're working with pain patients in particular, if they're eating a really bad diet and they're eating foods that are high in sugar, high in added sugars, if they're eating things that are known to be pro-inflammatory, like large protein foods like gluten, dairy, stuff like that, it could be contributing and adding a little bit of fuel to the fire of those pain signaling pathways. So again, just addressing the whole body, the whole system, the whole person, just reviewing what a healthy diet looks like, because some people, for whatever reason, still think that diet soda is healthy because it's diet. But get off my soapbox and back onto the lecture. So pathogenesis of neuropathic pain. So peripheral mechanisms after peripheral nerve lesion, neurons, they become more sensitive and they develop abnormal excitability and elevated sensitivity to stimulation. This is known as peripheral sensitization. So I know we had this in the lecture before, but I love this little image here. But the injured area, it becomes increasingly sensitive to sensory stimulation. Even light touch may become amplified to feel extremely painful. And remember, that's peripheral sensitization. That's hyperalgesia, a normal something that's normally, that's actually more so allodynia, right? If it's something that should be light touch and it's perceived as painful, that's more of an allodynic response. But you get those changes in the nervous system, you get ramped up upregulation of these pain signaling pathways, and then something that shouldn't be a noxious stimuli is perceived as noxious and it's painful for the patient. So that's peripheral sensitization, and then central mechanisms of the neuropathic pain. So as a consequence of that ongoing spontaneous activity that arises from that peripheral sensitization, the neurons develop an increased background activity and enlarged receptor fields and increased responses to afferent impulses, including normal tactile stimuli. So they're just in this heightened state of awareness that they can't get out of. I say, like they're wound up, right? And just to kind of go back on those receptive fields, remember every area in your body, they have receptive fields so that you can localize certain stimuli. In your hands, you're going to have very small receptive fields because you use your hands a lot, and they get smaller as we go up our arms. So these receptive fields get skewed, the maps in the brain get skewed, and then you start to perceive things that used to not be painful as painful information. So the normal pain processing, you get a painful stimuli, it goes up to the brain, you get all that good painful input that your brain perceives as pain, and then it sends some descending pain inhibitory pathways down. But if there is increased sensitization in the central pathways in the spinal cord, the nerve roots, and then also the brain, that minimal stimulation, it's going to create an induction of central sensitization, which leads to the abnormal pain processing. And you can see that increase or upregulation of neurotransmitter release, such as glutamate or substance P. Your brain's going to perceive the pain, but then it won't have that descending modulatory pathway working as efficiently as it could because you've just got too much fuel on the fire in that central pain pathway. And again, this is from the last lecture, but I really like this. This actually comes from a research article. They made a couple of these for a couple of different cases, but just something for you guys to read through. Neuropathic pain, it's caused by those lesions in the C, the A betas, the A deltas, and remember there's up to 4 Cs. And it just speaks about all this great information, some of the epidemiology that we already covered, what happens to the quality of life, which is really important to remember, some of the mechanisms behind neuropathic pain, which I know a lot of people know about. But one thing I haven't spoken much about is if you look into the right corner here, several mechanisms can contribute to the neuropathy, which includes the changes in function and expression of the voltage-gated sodium, calcium, potassium channels. So we have to remember too, this goes all the way down to those little elemental levels, right? So that's that environment that becomes a little bit too acidic and it doesn't alkalize the way it should, and you get those pain pathways just firing up. Medical management, you don't need to know it in particularly, but we should know because a lot of patients that we see, they're going to come in on some sort of medication. And I'll never forget this, I think it was like my first or second week in practice. I worked at a small town in North Carolina, and this older gentleman comes in, and he literally just decided one day he wasn't going to take any of his medications, and he was on a ton of medications. And we had to have a conversation with him and tell him, it's really important that you go back to your primary doc, you get a plan for getting off these medications because he'd been on them for so long. I was afraid we were going to have to escort him out in an ambulance because Lord knows what happens if your system gets so used to taking those medications and then you just all of a sudden decide like I'm done. So anyways, we don't have to know this for the test, but just knowing what some of the medications are, what some of the medications your patients might be on. And again, the only reason to know this really for us is if you're going to be prescribing any sort of supplementation, you don't want to do anything that would upregulate serotonin too much if they're on an SSRI or stuff like that. So good stuff to know. So the chronic neuropathic pain, it's more frequent in women and in patients greater than 50 years old. So sorry, 50-year-old women, you guys are the most likely to get the chronic neuropathic pain. Most commonly affects lower back and lower limbs, neck and upper limbs. I mostly see in my office diabetes mellitus, chronic neuropathic diabetes neuropathy, just because I live in Atlanta, Georgia, and we get some people from outside the city that drink Mountain Dew for breakfast, lunch, and dinner. So those are most of the neuropathic patients I see. But lumbar and cervical painful radiculopathies, they're probably the most frequent cause of chronic neuropathic pain. So that's something good to remember. A lot of people, we do a lot of work in the cervical and lumbar areas, but just something to remember. Okay, so headaches. I didn't want to go over too many different types of headaches. I know we could go really deep into all the different types of headaches, but I thought this paper did a decent job on discussing some of the neurophysiological mechanisms behind tension headaches. And I feel like tension headaches, I know a lot of you probably work with migraines and other types of headaches, but I feel like tension headaches play a huge role, and chiropractic care really does well with tension headaches as well as massage and other things. So despite being widely investigated, the pathogenesis of tension type headache is still under debate. And when was this paper written? 2010, so a little bit old, but it had some good information in it. A present model of tension type headache, pathophysiology, it underlines the importance of abnormal production of nociceptive substances in the development of pain and pericranial muscle tenderness. So again, even if we're doing muscle work with patients, sometimes if we can just address those peripheral chemical mechanisms that may be causing that sensitization by applying some sort of cream or a TENS unit or something like that, that may go a long way in getting the patient better and building plasticity positively to not have the patient suffer from a tension headache. So this is why I really like the paper. It gave a super awesome diagram. And again, whenever I think of tension headache, just kind of like osteoarthritis, I never really think of the chemical substrates that play a role in it. So I thought from a neurophysiological standpoint, this was an important paper to look into. So I'm not sure if I blew up. So what I did in the lecture here is I added a picture in from the paper of the pathway of what's causing some of the pain. But then what I did is down here, I just blew this up for you guys. And then I blew the picture up so you can see it and read through it. But I do want to read through this section here and just kind of go through the picture with you guys. So the tension type headache pathophysiology model. In genetically susceptible individuals, so not everybody, chronic stress, it can cause persistent elevation of glutamate, Glutamate is an excitatory neurotransmitter that we know plays a role in inflammation and pain. And the elevation of glutamate, it'll create some sort of stimulation of those NMDA receptors, which will activate what's called NF-kappa B. That leads to transcription of inducible nitric oxide and COX-2, among several other enzymes. So we're kind of right here in this little story. The high levels of inducible nitric oxide, which there's 3 different types of nitric oxide. There's inducible nitric oxide, there's endothelial nitric oxide, and then there's neuronal nitric oxide. And the inducible one, I always just see the I and I think inflammatory. It's the bad one, right? This is the one that you don't want active. This is the one we've got to shut down so that we can decrease the inflammatory pathways. But it'll cause vasodilation of the intracranial structures, such as the superior sagittal sinus, the nitrosative, and the nitrosative damage, so that inducible nitric oxide damage. It'll lead to pain from other structures, such as the dura. Pain is then conducted via the C fibers and some of the alpha fibers, and some of the A fibers neurons to the dorsal horn of the trigeminal nucleus. So you'll see that kind of going in here. The trigeminal nucleus, it lives in the trigeminal nucleus down here, and that's in the pons. So you'll see it fire into there. It'll fire up into the brain, and then it's just going to cause all sorts of issues. And you can see, like over here in the central sensitization pathway, I know we've gone through a lot of these with the different chemical mediators and receptors, but all this stuff is happening, which is creating some changes in the spinal cord, which is going to fire into, which is basically just going to create pain, right? So it's really important to, again, just address some of the chemical mediators and some of the dysfunction that those play a role in to help the patients get out of pain. So I'm going to backtrack a little bit. I kind of got off here, but at these synapses, primary nociceptive neurons will converge with some of the mechanoreceptor neurons that can be recruited via facilitation as part of the synaptic plasticity that leads to central sensitization. So again, these chemical mediators continuing to fire into these pathways will create central sensitization, which will create pain. So I won't read too much further into that, but I'll ask just like 1 or 2 questions on maybe some of the inducible nitric oxide, maybe glutamate getting upregulated when there's stress, and then what happens to some of the vasculature and the central mechanisms of it. Like, are you getting some central sensitization from these chemical mediators? Most likely you are. So I just really like that picture. Thought it did a good job of describing some of those pathways. And then although the central mechanisms and the sensitization are currently believed to play a central role in the tension type headache pathophysiology, chronic tension or contraction of the pericranial musculature has long been thought to be that primary cause. So, it depends on who you talk to. I don't think you can have any sort of muscular issue without some sort of chemical inflammatory component. So just as a reminder, the reason I put that in there and I wanted to talk about tension type headache in particular is because I think we always just go straight to the musculoskeletal issue of it, trying to release some of the tension in the musculature that can be contributing to the headache. And I don't think, I didn't at least until a few years ago really start trying to understand the chemical mediators and how they may be contributing to the inflammatory pathway. So you don't need to know anything specific, but just know that these guys are definitely playing a role in these musculoskeletal conditions. And if you have patients that are suffering from chronic pain and they're not getting better with whatever treatment that you're providing, and if you're not doing anything to address the chemical side of things and the peripheral sensitization, then that may be something that needs to be addressed to better create or have a better chance of creating neuroplasticity and shutting down pain. So that's all I have for this week. We have a couple more weeks left until your final exam, and thank you guys so much. Hope you have a great night.